think 10 years back, or maybe 12, and I saw a person putting screws inside a human being, and that was the first time I saw. I thought he must be a god, and his name turned out to be Ram. And that is what my association with Ram Chaddha, as you know him, he knows no introduction. And over a period, I had the opportunity to meet with him, interact with him. I even had the opportunity to sit with him. This is the first time I am sitting on the dais. You can see how proud I am there. Although he is getting bored, he has been in many conferences. But I have preserved the memory. The first memory of sharing dais with your master. And we had the opportunity to be an examiner with him for a DNB for DNB student out here in the very same auditorium where you are sitting. This is in this place itself. So that is how my journey is with my mentor, my master. He needs no introduction. He's a president-elect of Indian Orthopedic Society. So I present proudly Ram sir, my guru, my mentor, and he will talk about journey of a spine surgeon, my 10 mistakes. Over to you, Ram sir.
Good morning, everybody, and good evening to Neil Anand, whom I can see across on the screen right now. Great to see you, Neil. Dear friends, it's indeed a very proud moment to be invited here at the Railway Hospital and speak in front of a huge group of young, evolving spine surgeons. I believe spine surgery is something that we choose over many other easier options in orthopedics, and yet we feel that the best way forward is to have something difficult and challenging to do. I am going to now share my presentation, which I believe would be on this very laptop, and it's about how I have evolved since I passed my MS Orthopedics a year after Neil Anand did in the late 80s. And it was a very challenging time at that time when we moved from having X-rays, which used to be shot intraoperatively, and then the technician used to go all the way down 2 stories in Sion Hospital and then come back in 15-20 minutes with an image. And by then we would have already opened up things and made our assessment whether we were putting a guide wire into a pedicle or whether we were putting a guide wire into the hip. And I'm sure Neil had similar experiences at the Nair Hospital where he trained. And probably we also visited the cadaveric areas where we sort of self-trained. We didn't have these videos and YouTubes to help us. And we made more mistakes than most of you would today. I share with you the mistakes that I made, and I begin with what should be or would have been my last slide first. And I would want to begin this way because I would like to do justice to those 10 points. First and foremost, as a spine surgeon, I believed that I can make unhappy patients happy. I have now rephrased this. I say that I can make unhappy people less unhappy for some time. Please think about every word that I've said. I can make unhappy people less unhappy for some time. 2. Minimally invasive surgery will be a mid-path between non-surgical and surgical options in the spine. Minimally invasive surgery is not a mid-path, it is the future of spine surgery. And I believe every spine surgeon should have it as a part of his or her armamentarium. I've used the word her because we are having a lot of lady spine surgeons, and 3 days away from the International Women's Day, we should encourage them to be a part of our family. Spine surgery is an event and not a process. Gentlemen, spine surgery begins from the moment that that patient is either brought into or walks into your clinic. Counseling, counseling, and counseling before the operation and after the operation are an integral part of that small little event called spine surgery. We are responsible in person and vicariously for this entire experience, which may be anywhere between a few days to a few months at times. The process of how of the surgery is more important than the purpose why of the surgery. Gentlemen, why of the surgery is always more important. Why is more important than the how and finally the what. Whether it is uniportal, UBE, or whether it is fully endoscopic, is the what. Why are we operating? Is that the only option? Is what we need to think first. How to do it and what to do are coming much, much later. So always start with why. I also felt I am a spine surgeon. I should not be involved in non-surgical care. Gentlemen, we are ultimately the captains of the ship. It's our responsibility. What our secretary does, what our physiotherapist does, what the alternative medication guys may be doing, what the pain specialist may be doing, all of them have to be directly or indirectly under us, and we are responsible to give holistic care to the patient. I should have a greater share in decision making than the patient. We all talk of shared decision making. Gentlemen, it's shared, but I should not have the larger share. The patient should have the larger share. He or she has to buy the operation. Please do not sell the operation. Let them buy the operation. If they say, doctor, I'm feeling better, can we do it next week? Yes, sir. The only place where you step in is if you are convinced it's a cauda equina and you need to have an informed shared decision there. But otherwise, let them take a call. Please do not sell the operation. Why do I need a team to do spine surgery? I'm a minimally invasive surgeon. I'll walk with that scope in my pocket. I'll go anywhere in a small little clinic and do it. No, sir. We always need teams. As mentioned so rightly, in 1.92 seconds, they are a complete change of all the four wheels because of a team. TEAM is an acronym. Together, everyone achieves more. We have to work as a team. And have a team where you have something like a low PDI. What is PDI? PDI is power distance index. This is a terminology used in the aircrafts, in the airline industry, where you have a pilot and a co-pilot. The PDI has to be low. What is the meaning of PDI being low? If Ayush and I are working together, Ayush may be a few years younger than I am. On paper, he may have lesser years of experience. But Ayush, as a part of the team, should stop me the moment he identifies that I'm going wrong. He should not have 6 questions to say, Ram, do you think that you're doing something right? Is there some other way of doing it? Could this be similar to what we had the problem last time? No. He has to say, Ram, hold on. He has to stop, spot, and swap. So have a team member who can stop you, spot your problem, and swap before you go wrong. Have a low power distance index with your team. Nurses, junior assistants, fellows, everybody has the same right to speak and stop you. Most spine surgeries do not need ICU backup. No, sir. You may be the most brilliant spine surgeon in the world. You may be the most talented and you may be the greatest guy using that scope. Be somewhere around where there is an ICU, especially in high-risk patients. Please do not subject them because there's something beyond that surgery that we do that's unknown to us. No patient goes to the ICU because of our surgery, but goes because of the medical comorbidities. So be in the close vicinity of something where there is an ICU backup. For heaven's sake, please do not do it in very, very small setups where you can't handle those complications. I love this because we have always had this dig at neurosurgeons. I shall never have a neurosurgeon with me, I can do it all. No sir, please don't do that. None of us are gods. Where you need a neurosurgeon who is doing something which is different from what you are doing, work together as a team. At the end of the day, the patient needs that one surgery and the best at that time. So keep your ego aside, eject that ego out of you, and get somebody who can do something which you're not doing regularly with you. And finally, neuromonitoring is not really adding value to my surgery. Well, I was believing this till maybe 5-8 years back, but today I strongly believe that in the complex surgeries, neuromonitoring is adding immense value. So these are just 10 of the many things that I've learned. Ayush said, 10 bolna to maine 10 bol diye hain. But I'll now run through 3 decades of failures and the other lessons that I learned from it in a brief. Why are we doing this thing and what are we talking of, and why are we talking of failed back surgery syndrome? Because our failures teach us the most. 10 mistakes which I shared, and 3 types of those mistakes that come among these 10. Well, it's the primary detergent that a spine surgeon has in the process of achieving his holy grail. I spanned 3 decades since I've been doing surgery, and the lessons that I've learned. I have learned from what my patients taught me. We all have information, then we convert it to knowledge, and finally we crystallize wisdom out of it. A few of us get stuck with something called this Dunning-Kruger effect. Do you know what is the Dunning-Kruger effect? Dunning-Kruger effect is where we have ignorance, which then gets improved by information, and then information unfortunately does not become wisdom, and we have an illusion that we are very knowledgeable. So there are people who have a cognitive bias. They believe that they are superiorly talented and knowledgeable and have huge ability, and they do not have the knowledge that they do not have the knowledge to know. We all go through these 4 stages, and we need to go through those 4 stages, which is I don't know that I don't know, which is unconscious incompetence, to a stage of unconscious becoming conscious. So conscious incompetence, that's what we get to know as house surgeons, where our seniors tell us, nahi yaar, tere ko kuch nahi aata hai. That's conscious incompetence. Then we learn. Then we reach a stage of conscious competence, where most of you are today, where you know how good you are. That's the 3rd stage of conscious competence. And then finally we reach the stage of the masters who are sitting right in the front row, which is unconscious competence, where whatever they do, they will do it right every time. So you have to go through these 4 stages rather than skip it and have this Dunning-Kruger effect where you have a cognitive bias कि मुझे सब कुछ आता है, किसी को सब कुछ नहीं आता है. We are all learning and moving ahead. We have to move from wisdom to knowledge. Well, as I've said, you must learn from the SWOT analysis spoken by the previous speaker, which is strength, weakness, opportunity and threat, and convert adversity into advantage. When someone gives you lemons in life, make it into lemonade. And that's what we've done as orthopedic spine surgeons with neurospine surgeons and fellows in our group. Multiple complications over 30 years, 228 of them I've analyzed. I've also put them in 3 categories. This is the most important. Implant-related failed back surgery, surgery-related failed back surgery, and non-specific failed back surgery. 90, 72, and 66. The highest is in the top number, but they're easiest to handle. Well, most of them were our own. A few came from outside. Minimum follow-up was 18 months, maximum is 30 plus years. These patients were symptomatic and uncomfortable enough to buy another operation. There were many who got sorted out with lesser things, blocks, waiting, managing, going to some other Guruji, no problem. But then some of them needed surgery. I'm talking of the ones who needed surgery, implant related. What did they have? They had malposition, screws, cages which had backed out. Things went amiss. Everything went amiss. This is one of those many. I don't know who put this in and why it was put in, but I was surprised. I've never seen one before or after. But I was scared to take it out and I had to. It's a higher lumbar level. It was getting into the canal. The man had one-sided deficit which had come in recent onset. And believe me, I considered him for everything that could go wrong. Grace of God, it did come out and came out safely. I was lucky. This is yet another, came from overseas across the border. This man had lived for 3 years with this, with incalcit, with severe pain. All we needed to do was remove it and reposition it. That's what we did. Removed or repositioned. Some you have to remove and reposition. That's my own patient. That's this first Indian case that was ever devised almost about 15, 18 years back, where I was part to sort of creating that. And for some reason it popped out. The graft remained in front. This patient came back this is 6 weeks. At 6 weeks it came out. And I didn't know anything else. I went in at 6 weeks. Interestingly, I removed it and then I filled more graft in. I didn't have the courage to put another spacer in there because we had very limited of these spacers left. And there it did fuse. So I am trying to tell you that even at 6 weeks, there is some fibrous to fibrobony healing which is occurring in the front. And I gotten away with it. Second stage is where you had an adverse event or a sequelae in the surgery. Maybe infection, maybe a discitis, maybe adjacent segment. This is a back and front surgery which was done. The front remained clean, the back got septic and came after 6 months. I went in, cleaned up the back. Interestingly, the infection had not gone from the rear to the front and I took the advantage of just removing the implant from the rear and keeping the stability intact from the front, and we got away. We got away. This was basically septic with neurology and patient getting toxic, but it was 6 months, non-tuberculous, mind you, but low-grade pyogenic. This is probably the worst case that I can always share. 4-5 listhesis. I felt very, very happy. It started about 23 years back. And I went in and I was very, very proud that I could see some movement. I went in, put in a spacer. At that time I was using non-fusion options at the next level if I was decompressing 2 levels. So I put a knurled rod in the upper segment and a fusion at the lower level. I was very convinced that these things work. But unfortunately, beyond the knurled rod, I got an adjacent segment level at the end of 6 years. I went in and now removed the knurled rod and made a solid construct right up to the upper lumbar spine. I felt this is it. 2 years later, came back with an adjacent segment disease at the thoracolumbar junction. This time I felt now this is the best way. I've read about it. We have to go all the way across the thoracolumbar junction. So I went up to D10 and I told this patient, this is the 3rd surgery, you're going to do great. Well, by this time he was growing older and he was also getting osteoporotic. His wife was on teriparatide. I put him on teriparatide as well. I said, uncle, nothing to worry. This is the way forward. Came back to me in another couple of years with a huge popped out disc this time with neurology. The first few times there was no neurology, was only pain. This time there was neurology, so urgent surgery. I said no, D10 was not adequate. This time I'll go up to D4. So I went all the way up to D4 and I said, uncle, this is the last surgery. This is the best thing that you can have. Nothing will go wrong. By now he was 78 and it was time that he was sort of improving. He started walking around. He was very, very grateful that his bladder bowel had recovered and he was walking around with a walker though. And we said, uncle, don't worry. Another 6 months, less than 6 months maybe, came back with another disc that popped out at D3-4. And I said, now this is big trouble. By which time I realized that maybe with screws I should put wires. So I put in screws and wires and went up to D1. This time I said, uncle, now if it goes beyond this, we are both in trouble. Cervicothoracic junction. So it was D1 all the way up to the sacrum, which was actually the sacralized L5. And I said, uncle, now this is going to be big trouble if it ever goes beyond, because I have to now put a transition rod or something of that sort. Well, it was the last surgery. It's not that it lasted too long, but the patient didn't last too long. 6 months down the line, he had a cardiac issue and succumbed to it. Well, had he lasted longer, would I have had to go into the C-spine? Maybe. My guess is as good as yours. My story ended. This is in about 2019, started in 2002. But that's where we were. So this is adjacent segment disease. And I went through it, and then we have the third category. This is the most difficult to handle, where you've done everything well, everything looks well, the radiologist sees everything is well, everything is going fine. Patient is out of focus. It's the family that's unhappy with you, but there's something amiss. We call this non-specific back pain, failed back surgery, large number. What do these people need? They need no pharmacology. They need just advice and counseling, mental health consultations, depression and anxiety, and we've seen so many of them now post-COVID and right now. All of them are unhappy for some reason. They are unhappy and they're seeking for unhappiness within the surgery that you've done. So have effective communication with them, listen to them, respect their views, have open-ended decisions with them, let them take all the decisions, discuss all management options, allow them to ask as many questions as they want, ensure that they've understood, be aware of their language, accept their cultural influences, compensate all their communication skills. And finally, if you revise in the first category, they will do very well. In the second, you might need additional soft tissue like the adjacent segment that I told you. And in the third category, unfortunately, it's physiatry, painkiller, psychiatrists, psychologists, change of environment, whatever, everything put together, they have the worst results. Because you can't find a case. The first guys will go home in 4 days, the second will be 5.5 days, the third guys will keep getting admitted for pain blocks, coming again, going back, outpatient, inpatient. You will not find a cause, but you are the captain of the ship and you have to help them out. Yes, sometimes you use tissue sealants, dural, this, all that will happen in 1 and 2, but not in 3. Finally, as I said, the first will still have good results after the revision. The second, in between. The third, whatever you do, there are unhappy people who will become less unhappy for some time. Having said that, I would like to say that if you get obvious things which you can correct in failed back, go ahead and correct immediately. Don't sit on them. But those which are not obvious, share it with your colleagues. Let them go and see 2-3 other people who are like you. Let them go out. It's best to share and ask them for a second or a third or a fourth opinion before they go themselves. I do it very often. I have so many of my colleagues here to whom I refer them. यार इसको देख लो, मुझे कुछ नहीं मिल रहा, आप देख लो. Keep your ego aside. That's the best thing to do. And having said that, remember, ever tried, ever failed, no matter. Try again, fail better. That's what Samuel Beckett said. And I always believe in it. And I say this prayer of Reinhold Niebuhr called the Serenity Prayer every time that I begin a surgery. I say, God, grant me the serenity to accept things I cannot change, courage to change the things that I can, and wisdom to know the difference. Why is that so? Because as surgeons, spine surgeons specifically, we can only change the anatomy and hope that the change in anatomy improves the physiology. Never promise a physiological functional improvement. All you can do is change anatomy and hope that that change can change the physiology. We do not live in a perfect world. Always aim for excellence. You can probably become excellent, but perfection belongs to another universe. Thank you very much for a patient hearing.
Thank you so much, sir.